power of the situation is a term that refers to the idea that people's perceptions, emotions, thoughts, and behaviors tend to be influenced substantially by situational factors such as power structures, group pressure, the setting itself, defined roles, stressors, etc. Social psychologists, among all types of psychologists, are the ones who emphasize most the power of the situation, which is probably because some of the most famous experiments that have demonstrated the power of the situation, really in all of psychology, a couple of the most famous experiments are the Stanford Prison Experiment and Milgram's obedience studies. And both of these, especially the Stanford Prison Experiment, demonstrates the power of the situation to affect people's perceptions, their thoughts, their behaviors, their emotions. And it's a consistent theme among social psychologists to recognize the power of the situation. And one of the best examples of the power of the situation, along with the Stanford Prison Experiment, is the experiment known as on being sane in insane places. In this video, we will take a deep dive into this famous study. There's so much to analyze about it. And it's, again, the best way to explore this idea of the power of the situation. This is still worth reading on your own. There are parts of it that I'll skip, but it's just such an important study that I want to read it together. So here we go. The study was published, as you see, by David Rosenhan. I believe the year was, 1973, the study was published. And it goes like this. Here's the introduction. If sanity and insanity exist, how shall we know them? The question is neither capricious nor itself insane. However much we may be personally convinced that we can tell the normal from the abnormal, the evidence is simply not compelling. It is commonplace, for example, to read about murder trials wherein eminent psychiatrists for the defense are contradicted by equally eminent psychiatrists for the prosecution on the matter of the defendant's sanity. More generally, there are a great deal of conflicting data on the reliability, utility, and meaning of such terms as sanity, insanity, mental illness, and schizophrenia. Finally, as early as 1934, Benedict suggested that normality and abnormality are not universal. What is viewed as normal in one culture may be seen as quite aberrant in another. Thus, notions of normality and abnormality may not be quite as accurate as people believe they are. To raise questions regarding normality and abnormality is in no way to question the fact that some behaviors are deviant or odd. Murder is deviant. So too are hallucinations. Nor does raising such questions deny the existence of the personal anguish that is often associated with so-called mental illness. Anxiety and depression exist. Psychological suffering exists. But normality and abnormality, sanity and insanity, and the diagnoses that flow from them may be less substantive than many believe them to be. At its heart, the question of whether the sane can be distinguished from the insane, and whether degrees of insanity can be distinguished from each other, is a simple matter. Do the salient characteristics that lead to diagnoses reside in the patients themselves, or in the environments and contexts in which observers find them? From Bloiler to Kretschmer through the formulations of the recently revised Diagnostic and Statistical Manual of the American Psychiatric Association, the belief has been strong that patients present symptoms, that those symptoms can be categorized, and implicitly that the sane are distinguishable from the insane. More recently, however, this belief has been questioned, based in part on the theoretical and anthropological considerations, but also on philosophical, legal, and therapeutic ones. The view has grown that psychological categorization of mental illness is useless at best and downright harmful, misleading, and pejorative at worst. Psychiatric diagnoses, in this view, are in the minds of the observers and are not valid summaries of characteristics displayed by the observed. Gains can be made in deciding which of these is more nearly accurate by getting normal people, that is, people who do not have or have never suffered symptoms of serious psychiatric disorders, admitted to psychiatric hospitals. By getting normal people admitted to psychiatric hospitals and then determining whether they were discovered to be sane, and if so, how. If the sanity of such pseudo-patients were always detected, there would be evidence that a sane individual can be distinguished from the insane context in which he is found. Normality, and presumably abnormality, is distinct enough that it can be recognized wherever it occurs, for it is carried within the person. If, on the other hand, the sanity of the pseudo-patients were never discovered, serious difficulties would arise for those who support traditional models of psychiatric diagnosis. Given that the hospital staff was not incompetent, that the pseudo-patient had been behaving as sanely as he had been outside of the hospital, and that it had never been previously suggested that he belonged in a psychiatric hospital, such an unlikely outcome would support the view that psychiatric diagnosis betrays little about the patient, but much about the environment in which an observer finds him. This article describes such an experiment. 8 sane people gained secret admission to 12 different hospitals. Their diagnostic experiences constitute the data of the first part of this article. The remainder is devoted to a description of their experiences in psychiatric institutions. Too few psychiatrists and psychologists, even those who have worked in such hospitals, know what the experience is like. They rarely talk about it with former patients, perhaps because they distrust information coming from the previously insane. Those who have worked in psychiatric hospitals are likely to have adapted so thoroughly to the setting that they are insensitive to the impact of that experience. And while there have been occasional reports of researchers who submitted themselves to psychiatric hospitalization, these researchers have commonly remained in the hospitals for short periods of time, often with the knowledge of the hospital staff. It is difficult to know the extent to which they were treated like patients or like research colleagues. Nevertheless, their reports about the inside of the psychiatric hospital have been valuable. This article extends those efforts. Let's digest that, because many unexamined philosophical tenets about mental health were just exposed. And if you're not familiar with thinking through these issues in this way, this may be new to you. So here's what the author was getting at. Mental health is fundamentally different than physical health. They're very connected in many ways, but the diagnosis of mental disorders is a fundamentally different process than the diagnosis of physical diseases. Physical diseases are diagnosed through objective means. There's always some type of biological marker of a physical disease. And that's why you can confirm for sure. And granted, of course, there's often levels of interpretation going on by physicians when diagnosing physical diseases. But that's all there is when psychiatrists or psychologists diagnose mental disorders. It's only interpretation. There are no biological markers whatsoever for any condition in the DSM, which is the Book of Mental Disorders. I'll show it to you in a moment. Now, Sometimes we have, for certain conditions, especially the ones that are more distinctive, there are neurological correlates that appear to be associated with that condition. Now, it's not a 100% correlation. Otherwise, we would diagnose these conditions based on doing brain scans, but that's never done, of course. The way that a mental disorder is diagnosed is by looking at this manual, and we're now on the fifth edition of the DSM, the Diagnostic and Statistical Manual, which is published by the American Psychiatric Association, and there have been 5 major editions. First one came out 1952. Second one came out 1968. Third one came out in 1980. The fourth one came out in 1994. And the fifth one came out in 2013. And since the beginning, but especially the second and then the third version of the DSM, it has been fervently criticized. And that the critical voice that is scrutinizing the whole field of psychiatry and its fundamental paradigm, as well as the DSM, as well as the treatments that people have been subjected to. This has been happening for many decades, and I'm part of it. And I really appreciate every psychiatrist out there who is so well-intended and really helping people. But as the concepts, the paradigm, the philosophical basis of modern day and past practices in psychiatry is deeply flawed. And that is what the author in this article is talking about. So to better kind of contextualize this and I guess back up what I'm saying, I'll share a couple things. I'm going to share 3 things. First, I'll show you a letter from a group of psychologists who were able to read the DSM-5 back in 2012, 2013 when it was about to come out. And I want to read you their concerns about it. So this was an open letter, so a letter that was made public but directed to the leaders of the DSM and its development. So I'll read some of it, but then I have some parts that are highlighted, and I'll read those in particular. So how to interpret this is, I think this letter is representative of how many, if not most, psychologists think about the DSM. And if not most psychologists, then definitely most humanistic psychologists, which is a certain branch of psychology, as you may remember from an intro to psych class. So in 2011, as you see written, the British Psychological Society and the Society for Humanistic Psychology responded to the American Psychiatric Association's proposals for what would become the 5th edition of the DSM. Both professional bodies expressed concern that clients and the general public are negatively affected by the continued medicalization of their natural and normal responses to their experiences. Responses which undoubtedly have distressing consequences, which demand helping responses, but which do not reflect illnesses so much as normal individual variation. Scrolling down to this highlighted part, the diagnostic categories proposed by these frameworks, like the DSM and other similar manuals, are based largely on social norms about what constitutes normal or desirable behavior or experience. Their definitions inevitably rely on subjective judgments, which are themselves grounded in cultural norms. Scrolling down, significantly, diagnostic categories do not consistently predict response to medication or other interventions. One thing that these symptoms have in common is that they identify and locate problems within individuals, just like Rosenhan was saying. There is clear evidence that what one is exposed to, individually or as a collective, can have adverse impacts psychologically, behaviorally, and emotionally, including for future generations. For many people, the main cause of their experiences is found in the circumstances of their lives, Locating problems within only individuals misses the relational context and undeniable social and structural influences on many of these problems. Remember the fundamental attribution error. This is exactly what they're saying, that we are making a fundamental attribution error, at least for some, if not most, maybe all people who are diagnosed with mental disorders. We are saying that this is a disorder within you. You are exhibiting these problematic behaviors or experiencing this emotional distress because of something that is rooted in you. It's an internal attribution. That's what the diagnosis is. And importantly, remember that when we make an internal attribution, we assume that because it's rooted in you, that means that wherever you go, you will present those symptoms. It's independent of situational factors, whereas external attributions are saying that it's dependent on situational factors, or at least mostly triggered by situational factors. And therefore, if you were to be in a different situation, you would not exhibit those symptoms. From an ethical standpoint, they say, we should not minimize or ignore the social and structural origins of psychological suffering by instead reinterpreting that suffering as a result of deficits or disorder within the individuals affected by these problems. This has implications for care. In practice, diagnoses are not conferred in a contextual vacuum. Their criteria are not culture or value free, but are instead reflect current normative social expectations. Expectations about what you're supposed to act like in school, expectations about, essentially how you're supposed to be in the world, what kind of moods you're supposed to have. At the same time, psychiatric diagnoses have substantial impact on the social and occupational lives of those to whom they are applied. And reductionistic biomedical diagnoses obscure the social determinants of our distress. When we say that the reason that you're acting like this is because you have this disorder, we then fail to examine the social conditions that cause people to exhibit those behaviors. We make the fundamental attribution error and look no further. And the very big problem with that is when people are distressed or exhibiting problematic behavior because of conditions, because of the society they live in and the way it's structured, or the way their household is structured, we don't change those conditions. We don't even think to ourselves, well, maybe the reason that so many people are suffering so intensely is because our society is problematic. The way we've built our world, whether we're talking locally within a household, within a community, within a whole society, maybe the way we've built our world has problems and produces suffering. So that's the profound problem with this particular fundamental attribution error. We don't look at what is actually producing suffering. And then we don't change what is actually producing suffering, or again, just preventing human flourishing or giving rise to deviant behavior. A true paradigm shift, they go on to say, would start with recognition of the overwhelming empirical evidence that the experiences we call mental illness are understandable and essentially normal human responses, and that psychosocial and structural factors such as inequity, abuse, poverty, housing insecurity, unemployment, and trauma are the most robustly evidenced social determinants. So I will provide you with this letter. You can read the whole thing on your own if this is intriguing and important to you. To really bring into focus this idea that diagnoses are made by a subjective judgment, even if that person who is making the diagnosis has been trained thoroughly to differentiate, let's say, normal sadness and lethargy with clinical depression, because I do think for sure there are distinctions to be made, and we do need to figure out where are we going to allocate resources among all the people on the continuum of suffering or deviant behavior, who's exhibiting the most extreme symptoms, and where are we going to allocate resources. And I recognize that in order to make those decisions, we probably need official diagnoses, right? So I acknowledge that, and I recognize also that there are people who are very well trained in making that distinction, right? But again, it's still subjective. It's still interpretation. And it is extremely common that if a person goes to see a diagnosing physician like a psychiatrist or a clinician like a psychologist, and then they go get a second and third opinion, they will get different diagnoses. This happens all the time. And it's because that's what we mean by diagnostic reliability. There's a dramatic lack of diagnostic reliability and consistency. And that's because of what we're talking about. It's the subjective nature of the diagnosis, which is so fundamentally different than the relatively objective nature of diagnosing physical diseases. So to bring it into focus, as I was saying, I want to share with you the DSM, and I decided to just focus on ADHD since this is so commonly diagnosed. I want to be very clear right now. I know that a pretty high percentage of people watching this have been diagnosed with ADHD, or have a kid that has been diagnosed with ADHD, or a sibling, or a parent, or a friend. That is extremely likely, given the rate of this diagnosis. And I am not saying that you or your person isn't suffering or doesn't need support. But what I'm saying, and what so many people are saying, is that the behaviors that they're exhibiting, the cause of them is not necessarily rooted in that individual. And also, them being diagnosed with this condition was a subjective interpretation of their behavior. And here we will see very clearly what I mean by that. So let's look, right? So this is the diagnostic criteria of ADHD. There's two categories. The first is inattention. The second is impulsivity. In each of them, 6 or more of the following symptoms have persisted for at least 6 months to a degree that is inconsistent with developmental level and that negatively impacts directly on social and academic or occupational activities. Here are, I think there are nine. So you gotta check 6 out of the 9 of these boxes. Number 1, often fails to give close attention to details or makes careless mistakes. Often has difficulty sustaining attention in tasks or play activity. Often does not seem to listen when spoken to directly. Mind seems elsewhere, even in the absence of any obvious distraction. Often does not follow through on instructions and fails to finish schoolwork, chores, or duties. Often has difficulty organizing tasks. Often avoids, dislikes, or is reluctant to engage in tasks that require sustained mental effort. Often loses things necessary for tasks or activities, is often easily distracted by extraneous stimuli, is often forgetful in daily activities. Okay. And then for the impulsivity category, there are 9 here as well. And here's the first one. Often fidgets with or taps hands or feet or squirms in seat. Often leaves seat in situations when remaining seated is expected. Often runs about or climbs in situations where it is inappropriate. Often unable to play or engage quietly. Is often on the go, as if driven by a motor. Often talks excessively. Often blurts out an answer before a question has been completed. Often has difficulty waiting his or her turn. Often interrupts or intrudes on others, like butts into conversations, games, or activity. May start using other people's things without asking or receiving permission. back to that one that says is often on the go as if driven by a motor, they elaborate to say is unable to be or uncomfortable being still for extended time, as in restaurants, meetings, may be experienced by others as being restless or difficult to keep up with. Okay, so every single criterion begins with the word often. And perhaps we're just assuming that we can all use common sense about what often means. But that's not how any other branch of medicine conducts itself. Psychiatry is different. And not just the word often, but all of those behaviors, they are interpreted. Like often talks excessively. How often is often? How excessive is excessive? It's in the eye of the beholder. The diagnostic criteria for this condition and many others have just gotten looser and looser through the additions of the DSM, and therefore the net has been cast wider. And more people now qualify for conditions who would have not qualified for it the day before the DSM-5 came out. So we're talking about two things here. First of all, let me make this really clear. One, the subjective nature of making a diagnosis. And because it's so subjective, that means that the situation, the power of the situation, will exert great influence over making that judgment, right? If you are HIV positive, you are HIV positive everywhere you go. It is literally completely independent of where you are, right? This context, the situation, the circumstances you're in are irrelevant. You will test as HIV positive, period, no matter what. If you have been diagnosed with ADHD, it is not like that. Let me show you an example of what I mean. This is the same boy. As you see, 10-minute time-lapse video. On the left, he's watching a math video. On the right, he's watching Star Wars. This boy's been diagnosed with ADHD, right? And on the left, he seems to fit the criteria. He's squirming in his seat. He's having trouble sitting still. He's clearly having a hard time paying attention. And we tend to assume that that's because he has this condition. But what about the boy on the right? Well, he doesn't have this condition. He's exhibiting none of those symptoms. But here's the problem. It's the same boy. The difference is essentially the environment, the input going into his brain, what he's experiencing while watching Star Wars. He is enthralled. It's extremely compelling. So that's what we mean. In different contexts, people are different, and they may qualify for a disorder in one context, but not another. And the problem might not be with them. The problem might be that we're not, like that math video is too boring, or that's not the right way he needs to be learning math. But no one seems to be thinking like that. It just seems like the norm is to look at him and be like, oh, yep, he's got a problem. No, don't worry about the math video. That's fine. I'm sure that's good enough to keep his attention. And granted, again, like I recognize people, there's a lot of smart people that I may be criticizing right now who I want to be fair, right? I want to do this all in good faith. And if he's the only, like if he is among 20 other students who are watching that same math video and 19 of them are able to sit still, then we're even much more inclined to think, okay, clearly there's something going on with him because look, all these other 19 kids were able to sit still. But still, that still doesn't mean that he has a disorder. It may just mean he's a different type of person whose attention needs to be maintained in a more engaging way. I often say people who experience inattentiveness, people who are easily distracted, people who would typically be diagnosed with ADHD, they are the canaries in the coal mine of boring. They are the first to show. They are the most sensitive to meaninglessness, boring things, boring environments, boring lessons, boring movies, boring experiences. And for me, for example, as a psychology professor, when I am teaching to a class, again, there's certain people that are the quickest to like pull out their phone and start looking at it and appear to be distracted. And I appreciate their presence because it's feedback for me. It's the canary in the coal mine that comes back and tells the coal miner that, hey, it's boring in there, because they're more sensitive to it. They're quicker to react to it. And I don't see that as anything wrong with them, right? Like I attribute their behavior to myself. I'm like, it must be me. And often I think that's true. Okay, and then just one more thing I'll say. I know we're like in the weeds, we're in the nuances right now, so I appreciate you taking this journey with me. And I know all this is being said after only reading the introduction to the study. But the one more thing I'll say is everything I just said about like teaching a class and someone getting distracted. Is it possible that the person is really too easily distracted? Of course. Is it possible that someone could be really listening or having an experience that kind of should be very engaging, and yet still they're being distracted or they're very impulsive? Of course. And is that ever problematic? Definitely. But when we diagnose people as having ADHD and we attribute those behaviors to their ADHD, we unconsciously, we assume that this is how they are, and a fixed mindset sets in. And we start every single time the person is distracted or impulsive, we think, oh, that's because they have ADHD. But we never really think, well, this person's brain is just as plastic as others. It's capable of developing impulse control and focus. We don't say that. But it's true. Literally everybody, regardless of what your baseline level of capacity to focus and impulse control is, everyone can improve upon it. I've said some of the things I'm saying right now publicly and gotten a surprising backlash from the people who need me to know that it's kind of offensive for me to suggest that they can improve upon their ability to focus or control their impulses. They need me to know that their brain really does work differently. And I take that to heart. I get that. But their difference is more like just a difference in their personality type. The difference is not that they have a mental disorder. That's my stance. So with fully honoring people's experiences and challenges, we can also acknowledge that there's a very problematic way in which we are thinking about problematic behaviors. One last thing before we dive back into the study and fully focus on that. In 2023, the United Nations, in collaboration with the World Health Organization, published what is known as the Guidance. And this essentially says that current practices in the field of mental health violate human rights. I'll go to a slide I've created here that captures some of the most important statements, I think, from the guidance. And I will also provide you with the document here, the PDF, for you to explore. But as you see written, after years of work involving hundreds of people in dozens of countries, the World Health Organization and the United Nations Office of the High Commissioner for Human Rights have released their joint production referred to as the guidance. These organizations concluded the following. The biomedical model, which focuses predominantly on diagnosis, medication, and symptom reduction, prevails across existing mental health systems. As a result, social determinants that impact people's mental health are often disregarded. A fundamental shift is required within the field of mental health. There is an over-reliance on biomedical approaches to treatment options in patient services and care, and little attention given to social determinants and community-based person-centered interventions. Most legislation on mental health fails to embrace a rights-based approach. Many people are not treated equally before and under the law and are often discriminated against. Legislation may be paternalistic. People are routinely deemed incapable of making decisions. There are no adequate mechanisms to prevent, detect, or remedy these and other human rights violations. The international human rights framework requires a transformation in the way mental health services are provided. All persons should be able to exercise their right to give free and informed consent to accept or reject treatment in mental health systems. Denial of legal capacity, coercive practices, and institutionalization must end. The different ways of being, thinking, sensing, or expressing and making sense of the world are part of human diversity. There is no normal or right way to be. A failure to understand and respect these differences can lead to isolation and discrimination. Thank you for taking that journey with me. I am eager to engage with you about it and clarify anything, answer questions, hear you out, understand how you're processing this. I would love to do that. Let's get back to our study. The 8 pseudo-patients were a varied group. One was a psychology graduate student in his 20s. The remaining 7 were older and established. Among them were 3 psychologists, a pediatrician, a psychiatrist, a painter, and a housewife, he says in the 1970s. These pseudo-patients were women, 3 pseudo-patients were women, 5 were men. All of them employed pseudonyms, lest their alleged diagnoses embarrass them later. Those who were in mental health professions alleged another occupation in order to avoid the special attentions that might be accorded by staff as a matter of courtesy or caution to ailing colleagues. With the exception of myself, I was the first pseudo-patient, he says, and my presence was known to the hospital administrator and chief psychologist, and so far as I can tell, to them alone. So with the exception of him, the presence of pseudo-patients and the nature of the research program was not known to the hospital staff. The settings were similarly varied. In order to generalize the findings, admission into a variety of hospitals was sought. The 12 hospitals in the sample were located in 5 different states on the east and west coasts. Some were old and shabby, some were quite new, some were research-oriented, others not. Some had good staff-patient ratios, others were quite understaffed. Only one was a strictly private hospital. All of the others were supported by state or federal funds, or in one instance by university funds. I'm not totally sure how that makes sense, that they had 12 different hospitals. I'm not aware, maybe we'll discover that as we read closely here, if there was only 8 pseudo-patients, so maybe a couple of them did time at different hospitals, or they just sought out those hospitals and then ended up using 8 of them. Not totally sure about that, but in any case, a wide variety of hospitals were represented in this study. After calling the hospital for an appointment, the pseudo-patient arrived at the admissions office complaining that he had been hearing voices. Asked what the voices said, he replied that they were often unclear, but as far as she could tell, they said empty, hollow, and thud. The voices were unfamiliar and were of the same sex as the pseudo-patient. The choice of these symptoms were occasioned by their apparent similarity to existential symptoms. Such symptoms are alleged to arise from painful concerns about the perceived meaninglessness of one's life. It is as if the hallucinating person were saying, "My life is empty and hollow." The choice of these symptoms was also determined by the absence of a single report of existential psychoses in literature. So what they're saying right there is they chose these symptoms honestly kind of to see if any diagnosing physician would recognize that these symptoms tend to be associated with an existential crisis and might not reflect a mental disorder. But of course, no one thought of that. So beyond alleging the symptoms and falsifying name, vocation, and employment, no further alterations of person, history, or circumstances were made. The significant events of the pseudopatient's life history were presented as they had actually occurred. Relationships with parents and siblings, with spouse and children, with people at work and in school, consistent with the aforementioned exceptions, were described as they were or had been. Frustrations and upsets were described along with joys and satisfactions. These facts are important to remember. If anything, they strongly biased the subsequent results in favor of detecting sanity, since none of their histories or current behaviors were seriously pathological in any way. Okay. Immediately upon admission to the psychiatric ward, the pseudopatient ceased simulating any symptoms of abnormality. In some cases, there was a brief period of mild nervousness and anxiety, since none of the pseudopatients really believed that they would be admitted so easily. Indeed, their shared fear was that they would be immediately exposed and frauds and greatly embarrassed. Moreover, many of them had never visited a psychiatric ward. Even those who had, nevertheless, had some genuine fears about what might happen to them. Their nervousness then was quite appropriate to the novelty of the hospital setting, and it abated rapidly. Apart from that short-lived nervousness, the pseudopatient behaved on the ward as he or she normally behaved. The pseudopatient spoke to patients and staff as he might ordinarily. Because there is uncommonly little to do on a psychiatric ward, he attempted to engage others in conversation. When asked by staff how he was feeling, he indicated that he was fine, that he no longer experienced symptoms. He responded to instructions from attendants, to calls for medication which was not swallowed, and to dining hall instructions. Beyond such activities as were available to him on the admissions ward, he spent his time writing down his observations about the ward, its patients, and the staff. Initially, these notes were written secretly, but as soon as it became clear that no one much cared, they were subsequently written on standard tablets of paper in such public places as the day room. No secret was made of these activities. The pseudopatient, very much as a true psychiatric patient, entered a hospital with no foreknowledge of when he would be discharged. Each was told that he would have to get out by his own devices, essentially by convincing the staff that he was sane. The psychological stresses associated with hospitalization were considerable, and all but one of the pseudopatients desired to be discharged almost immediately after being admitted. They were, therefore, motivated not only to behave sanely, but to be paragons of cooperation. That their behavior was in no way disruptive is confirmed by nursing reports which have been obtained on most of the patients. These reports uniformly indicate that the patients were friendly, cooperative, and exhibited no abnormal indications. Next section, the normal are not detectably sane, right? In other words, sane people are not detectably sane people when they are in insane environments. So here we go. Despite their public show of sanity, the pseudopatients were never detected. Admitted, except in one case, with a diagnosis of schizophrenia, each was discharged with a diagnosis of schizophrenia in remission. The label in remission should in no way be dismissed as a formality, for at no time during any hospitalization had any question been raised about any pseudopatient's simulation, nor are there any indications in the hospital records that the pseudopatient's status was suspect. Rather, the evidence is strong that once labeled schizophrenic, the pseudopatient was stuck with that label. If the pseudopatient was to be discharged, he must naturally be in remission, but he was not sane, nor, in the institution's view, had ever been sane. The uniform failure to recognize sanity cannot be attributed to the quality of the hospitals, for although there were considerable variations among them, several are considered excellent. Nor can it be alleged that there was simply not enough time to observe the pseudopatient. Length of hospitalization ranged from 7 to 52 days, with an average of 19 days. The pseudopatients were not, in fact, carefully observed, but this failure clearly speaks more to traditions within psychiatric hospitals than to lack of opportunity. Finally, it cannot be said that the failure to recognize the pseudopatient's sanity was due to the fact that they were not behaving sanely. While there was clearly some tension present in all of them, their daily visitors could detect no serious behavioral consequences, nor indeed could other patients. It was quite common for the patients to detect the pseudopatient's sanity. During the first 3 hospitalizations, when accurate counts were kept, 35 of a total of 118 patients on the admissions ward voiced their suspicions, some vigorously. You're not crazy, you're a journalist or a professor. You're checking up on the hospital. While most of the patients were reassured by the pseudo-patient's insistence that he had been sick before he came in but was fine now, some continued to believe that the pseudo-patient was sane throughout his hospitalization. So the patients, the actual patients in there, started suspecting that the pseudo-patients were not actual patients. The fact that the patients often recognized normality when staff did not raises important questions. Failure to detect sanity during the course of hospitalization may be due to the fact that physicians operate with a strong bias toward what statisticians call the type 2 error. That this is to say that physicians are more inclined to call a healthy person sick a false positive than a sick person healthy, which is a false negative. The reasons for this are not hard to find. It is clearly more dangerous to misdiagnose illness than health. Better to err on the side of caution, to suspect illness even among the healthy. But what holds for medicine does not hold equally well for psychiatry. Medical illnesses, while unfortunate, are not commonly pejorative. Psychiatric diagnoses, on the contrary, carry with them personal, legal, and social stigmas. It was therefore important to see whether the tendency toward diagnosing the sane insane could be reversed. The following experiment was arranged at a research and teaching hospital whose staff had heard these findings but doubted that such an error could occur in their hospital. So he's describing a different experiment right now related to the big one that we're talking about. But this was like a little mini experiment, right? So one hospital heard the news that this experiment went on, and they were like, oh, that would never happen here. And so then this researcher was like, all right, well, let's see. So the staff of that hospital was informed that at some time during the following 3 months, one or more pseudo patients would attempt to be admitted into the psychiatric hospital. Each staff member was asked to rate each patient who presented himself at admissions or on the ward according to the likelihood that the patient was a pseudo-patient. A 10-point scale was used with a 1 and 2 reflecting high confidence that the patient was a pseudo-patient. Judgments were obtained on 193 patients who were admitted for psychiatric treatment. All staff who had had sustained contact with or primary responsibility for the patient, attendants, nurses, psychiatrists, physicians, and psychologists, were asked to make judgments. 41 patients were alleged with high confidence to be pseudo-patients by at least one member of the staff. 23 were considered suspect by at least one psychiatrist. 19 were suspected by one psychiatrist and one other staff member. And actually, no genuine pseudo-patients presented himself during this time period. So they primed the hospital staff to look for normality by telling them, lying, tricking them into thinking that there were pseudo-patients in their midst. And of course, the hospital staff, they're motivated to not be duped. They don't want to succumb to what the other hospitals succumbed to in the study we're reading about. They don't want to fail to recognize sanity, right? So these researchers very cleverly primed them to see normality. And what do you know? When they were primed to see normality, they saw normality. This is very significant. So Rosenhan goes on to say the experiment is instructive. It indicates that the tendency to designate sane people as insane can be reversed when the stakes, in this case prestige and diagnostic acumen, are high. But what can be said of the 19 people who were suspected of being sane by a psychiatrist and other staff member? Were these people truly sane? Or was it rather the case that in the course of avoiding the type 2 error, the staff tended to make errors of the first sort, calling the crazy sane? There is no way of knowing, but one thing is certain. Any diagnostic process that lends itself so readily to massive errors of this sort cannot be a very reliable one. A section here on the stickiness of psychodiagnostic labels. Beyond the tendency to call the healthy sick, a tendency that accounts better for diagnostic behavior on admission than it does for such behavior after a lengthy period of exposure, the data speak to the massive role of labeling in psychiatric assessment. Having once been labeled schizophrenic, there is nothing the pseudo-patient can do to overcome the tag. The tag profoundly colors others' perceptions of him and his behavior. So this is stigma. The author goes on to say, from one viewpoint, these data are hardly surprising, for it has long been known that elements are given meaning by the context in which they occur. Gestalt psychology made this point vigorously, and Ash demonstrated that there are central personality traits which are so powerful that they markedly color the meaning of other information in forming an impression of a given personality. Insane, schizophrenic, manic depressive, and crazy are probably among the most powerful of such central traits. Once a person is designated abnormal, all of his behaviors and characteristics are colored by that label. Indeed, that label is so powerful that many of the pseudo-patient's normal behaviors were overlooked entirely or profoundly misinterpreted. Some examples may clarify this issue. Earlier, I indicated that there were no changes in the pseudo-patient's personal history and current status beyond those of name and stuff. Otherwise, a veridical description of personal history and circumstances was offered. Those circumstances were not psychotic. So how were they made consonant or consistent with the diagnosis of psychosis? Or were those diagnoses modified in such a way as to bring them in accord with the circumstances of the pseudo-patient's life as described by him? The question here is, the personal history does not match the current condition. So which one's got to give in order for them to be made consistent? Because personal histories should match current conditions. And so the question here is, well, are they going to question their label of their current condition once they learn that the personal history is actually has no reasonable cause of schizophrenia? Or are they going to reinterpret the personal history and see into it a cause of psychosis? So the author goes on to say, as far as I can determine, diagnoses were in no way affected by the relative health of the circumstances of the pseudo-patient's life. Rather, the reverse occurred. The perception of his circumstances was shaped entirely by the diagnosis. A clear example of such translation is found in the case of a pseudo-patient who had a close relationship with his mother, but was rather remote from his father during his early childhood. During adolescence and beyond, however, his father became a close friend, while his relationship with his mother cooled. His present relationship with his wife was characteristically close and warm. Apart from occasional angry exchanges, friction was minimal. The children had rarely been spanked. Surely there is nothing especially pathological about such a history. Indeed, many readers may see a similar pattern in their own experiences with no markedly deleterious consequences. Observe, however, how such a history was translated in the psychopathological context. This from the case summary prepared after the patient was discharged. This white 39-year-old male, manifests a long history of considerable ambivalence in close relationships, which begins in early childhood. A warm relationship with his mother cools during his adolescence. A distant relationship with his father is described as becoming very intense. Affective stability is absent. His attempts to control emotionality with his wife and children are punctuated by angry outbursts and, in the case of the children, spankings. And while he says that he has several good friends, one senses considerable ambivalence embedded in those relationships also. Would one sense that if this person didn't have a diagnosis of a mental illness? Probably not. The facts of the case were unintentionally distorted by the staff to achieve consistency with a popular theory of the dynamics of a schizophrenic reaction. Nothing of an ambivalent nature had been described in relationships with parents, spouse, or friends. To the extent that ambivalence could be inferred, it was probably not greater than is found in all human relationships. It is true that the pseudopatient's relationships with his parents changed over time, but in the ordinary context, that would hardly be remarkable. Indeed, it might very well be expected. Clearly, the meaning ascribed to his verbalizations was determined by the diagnosis, schizophrenia. An entirely different meaning would have been ascribed if it were known that the man was normal. All pseudopatients took extensive notes publicly. Under ordinary circumstances, such behavior would have raised questions in the minds of observers, as, in fact, it did among patients. Indeed, it seemed so certain that the notes would elicit suspicion that elaborate precautions were taken to remove them from the ward each day. But the precautions proved needless. The closest any staff member came to questioning these notes occurred when one pseudopatient asked his physician what kind of medication he was receiving and began to write it down. The response, "You needn't write it," he was told gently. "If you have trouble remembering, just ask me again." If no questions were asked of the pseudopatients, how was their writing interpreted? This is a good question, right? So no one was really asking them why you're writing notes so often, but assumptions were made about why these people were writing notes often. So nursing records for 3 patients indicate that the writing was seen as an aspect of their pathological behavior. Patient engages in writing behavior was the daily nursing comment on one of the pseudopatients who was never questioned about his writing. Given that the patient is in the hospital, he must be psychologically disturbed. And given that he is disturbed, continuous writing must be a behavioral manifestation of that disturbance, perhaps a subset of the compulsive behaviors that are sometimes correlated with schizophrenia, right? So it must be because he's insane. One tacit characteristic of psychiatric diagnosis is that it locates the sources of aberration within the individual, and only rarely within the complex of stimuli that surrounds him, as we've been emphasizing. Consequently, behaviors that are stimulated by the environment are commonly misattributed to the patient's disorder. For example, one kindly nurse found a pseudopatient pacing the long hospital corridors. "Nervous, Mr. X?" she asked. "No, bored," he said. The notes kept by pseudopatients are full of patient behaviors that were misinterpreted by well-intentioned staff. Often enough, a patient would go berserk because he had, wittingly or unwittingly, been mistreated by, say, an attendant. A nurse coming upon the scene would rarely inquire, even cursorily, into the environmental stimuli of the patient's behavior. Rather, she assumed that his upset derived from his pathology. This is the "couldn't be me" attribution. Rather, she assumed that his upset derived from his pathology, not from her mistreating him. Occasionally, the staff might assume that the patient's family or other patients had stimulated the outburst, but never were the staff found to assume that one of themselves or the structure of the hospital had anything to do with the patient's behavior. One psychiatrist pointed to a group of patients who were sitting outside the cafeteria entrance half an hour before lunchtime. To a group of young residents, he indicated that such behavior was characteristic of the oral acquisitive nature of the syndrome. So picture that scene, right? The psychiatrist is walking around with residents, like interns, young, aspiring psychiatrists. And he points to this group of patients who are sitting outside the cafeteria half an hour before lunchtime. And he says, oh, look, this is characteristic of the oral acquisitive nature of the syndrome. It seemed not to occur to him that there were very few things to anticipate in a psychiatric hospital besides eating. So it's not because they're hungry, it's because they're crazy that they're sitting here. A psychiatric label has a life and an influence of its own. Once the impression has been formed that the patient is schizophrenic, the expectation is that he will continue to be schizophrenic. When a sufficient amount of time has passed, during which the patient has done nothing bizarre, he is considered to be in remission and available for discharge. But the label endures beyond the discharge, with an unconfirmed expectation that he will behave as a schizophrenic again. Such labels conferred by mental health professionals are as influential on the patient as they are on his relatives and friends. Such labels conferred by mental health professionals are as influential on the patient as they are on his relatives and friends, and it should not surprise anyone that the diagnosis acts on all of them as a self-fulfilling prophecy. Eventually, the patient himself accepts the diagnosis with all of its surplus meanings and expectations and behaves accordingly. The inferences to be made from these matters are quite simple. There is enormous overlap in the symptoms presented by patients who have been variously diagnosed, so there is enormous overlap in the behaviors of the sane and the insane. The sane are not sane all of the time. We lose our tempers for no good reason. We are occasionally depressed or anxious, again, for no good reason. And we may find it difficult to get along with one or another person, again, for no reason that we can specify. Similarly, the insane are not always insane. Indeed, it was the impression of the pseudo-patients while living with them that they were sane for long periods of time, that the bizarre behaviors upon which their diagnoses were allegedly predicated constituted only a small fraction of their total behavior. If it makes no sense to label ourselves permanently depressed on the basis of an occasional depression, then it takes better evidence than is presently available to label all patients insane or schizophrenic on the basis of bizarre behavior or cognitions. It seems more useful to limit our discussion to behaviors, the stimuli that provoke them, and their correlates. It is not known why powerful impressions of personality traits such as crazy or insane arise. Conceivably, when the origins of and stimuli that give rise to a behavior are remote or unknown, or when the behavior strikes us as immutable, trait labels regarding the behavior arise. When, on the other hand, the origins and stimuli are known and available, discourse is limited to the behavior itself. Thus, I may hallucinate because I am sleeping, or I may hallucinate because I have ingested a peculiar drug. These are termed sleep-induced hallucinations, respectively. But when the stimuli to my hallucinations are unknown, that is called craziness or schizophrenia, as if that inference were somehow as illuminating as the others. So when we know the obvious causes of someone's behavior, we don't pin the source of that behavior on the person. But when we don't know the causes of the behavior, we do pin the source of that behavior on the person. But the problem is, there are still causes of that behavior. We just haven't identified them. And once we pin the source of the behavior on the person, we stop looking for those situational factors that are giving rise to this behavior. Okay, so we're on a marathon right now, and you are working hard. So let's do this. Let's keep going. The experience of psychiatric hospitalization. This is interesting. We're going to hear what it was like. So the term mental illness is of recent origin. It was coined by people who were humane in their inclinations and who wanted very much to raise the station of the psychologically disturbed from that of witches and crazies to one that was akin to the physically ill. And they were at least partially successful, for the treatment of the mentally ill has improved considerably over the years. He's saying this in the 70s. But while treatment has improved, it is doubtful that people really regard the mentally ill in the same way that they view the physically ill. A broken leg is something one recovers from, but mental illness allegedly endures forever. A broken leg does not threaten the observer, but a crazy schizophrenic? There is by now a host of evidence that attitudes toward the mentally ill are characterized by fear, hostility, aloofness, suspicion, and dread. The mentally ill are society's lepers. And I'll just add to that, along with the perception of the mentally ill, giving rise to like attitudes of fear, hostility, aloofness, suspicion, or dread, I would also add simply that they are not taken as seriously. And that is incredibly demeaning. Okay, that such attitudes infect the general population is perhaps not surprising, only upsetting, but that they affect the professionals who treat and deal with the mentally ill is more disconcerting, both because such attitudes are self-evidently pernicious and because they are unwitting. Most mental health professionals would insist that they are sympathetic toward the mentally ill, that they are neither avoidant nor hostile. But it is more likely that an exquisite ambivalence characterizes their relations with psychiatric patients, such that their avowed impulses are only part of their entire attitude. Negative attitudes are there too and can easily be detected. Such attitudes should not surprise us. They are the natural offspring of the labels that patients wear and the places in which they are found. So this is the power of the situation. The label that you are given, the role you are cast into, the setting and the meaning of all of this setting, the setting and the role and the label and everything, the whole picture here constitutes the situation, and it has immense power over the way that people are perceiving each other, thinking about each other, acting toward each other. Consider the structure of the typical psychiatric hospital. Okay, pausing to say that the next few paragraphs, they talk about how often the hospital staff emerged from their staff area. And in the interest of saving some energy in this marathon, I'll let you read that part by yourself. But basically, if you want to skip it, the answer is very little, very, very little. The staff rarely ever meaningfully interacted with the patients. I'm going to jump ahead because they talk about the nurses, they talk about the physicians, and basically the higher up, the higher the rank, the more authority that the staff member had, the less time they spent observing patients. So as I'm skimming through, I will highlight one particular important sentence. Those with the most power have least to do with patients, and those with the least power are most involved with them. Jumping ahead, the author says, I turn now to a different set of studies, these dealing with staff response to patient-initiated contact. It has long been known that the amount of time a person spends with you can be an index of your significance to him. If he initiates and maintains eye contact, there is reason to believe that he is considering your requests and needs. If he pauses to chat or actually stop and talks, there is added reason to infer that he is individuating you. In 4 hospitals, the pseudo-patients approached the staff member with a request which took the following form. Pardon me, Mr. or Dr. X, could you tell me when I will be eligible for grounds privileges, or when I will be presented at the staff meeting, when I am likely to be discharged? Questions like this. While the content of the question varied according to the appropriateness of the target and the pseudo-patient's current needs, the form was always a courteous and relevant request for information, okay? So they approach staff members with a courteous and relevant request for information. Care was taken to never approach a particular member of the staff more than once a day, lest the staff member become suspicious or irritated. In examining these data, remember that the behavior of the pseudo-patients was neither bizarre nor disruptive. One could indeed engage in good conversation with them, okay? So, minor differences between these four institutions were overwhelmed by the degree to which staff avoided continuing contacts that patients had initiated. By far, their most common response consisted of either a brief response to the question offered while they were on the move and with head averted, or no response at all. The encounter frequently took the following bizarre form. Pseudo-patient would say, "Pardon me, Dr. X, could you tell me when I'm eligible for grounds privileges?" And the physician would say, "Good morning, Dave. How are you today?" Moves off without waiting for a response. It is instructive to compare these data with data recently obtained at Stanford University. It has been alleged that large and eminent universities are characterized by faculty who are so busy that they have no time for students. For this comparison, a young lady approached individual faculty members who seemed to be walking purposefully to some meeting or teaching engagement and asked them the following 6 questions. "Pardon me, could you direct me to Encina Hall?" Or, "Do you know where the fish annex is?" There is no fish annex at Stanford. "Do you teach here? How does one apply for admission to the college? Is it difficult to get in? Is there financial aid?" Without exception, all of the questions were answered. No matter how rushed they were, all respondents not only maintained eye contact, but stopped to talk. Indeed, many of the respondents went out of their way to direct or take the questioner to the office she was seeking, or to try to locate this fish annex, or to discuss with her the possibilities of being admitted to the university. So we are comparing the power of two extremely different situations, settings, a mental hospital and Stanford University. Okay, jumping ahead to this section on powerlessness and depersonalization. Eye contact and verbal contact reflect concern and individuation, me seeing you as a distinct individual. Their absence, avoidance, and depersonalization. The data I have presented do not do justice to the rich daily encounters that grew up around matters of depersonalization and avoidance. I have records of patients who were beaten by staff for the sin of having initiated verbal contact. During my own experience, for example, one patient was beaten in the presence of other patients for having approached an attendant and told him, "I like you." Occasionally, punishment meted out to patients for misdemeanors seemed so excessive that it could not be justified by the most radical interpretations of psychiatric canon. Nevertheless, they appeared to go unquestioned. Tempers were often short. A patient who had not heard a call for medication would be roundly excoriated, and the morning attendants would often wake patients with, "Come on, you motherfuckers, out of bed." Neither anecdotal nor hard data can convey the overwhelming sense of powerlessness which invades the individual as he is continually exposed to the depersonalization of the psychiatric hospital. It hardly matters which psychiatric hospital. The excellent public ones and the very plush private hospital were better than the rural and shabby ones in this regard, but again, the features that psychiatric hospitals had in common overwhelmed by far their apparent differences. Powerlessness was evident everywhere. The patient is deprived of many of his legal rights by dint of his psychiatric commitment. He is shorn of credibility by virtue of his psychiatric label. His freedom of movement is restricted. He cannot initiate contact with the staff, but may only respond to such overtures as they make. Personal privacy is minimal. Patient quarters and possessions can be entered and examined by any staff member for whatever reason. His personal history and anguish is available to any staff member who chooses to read his folder, regardless of their therapeutic relationship to him. His personal hygiene and waste evacuations are often monitored. The water closets may have no doors. At times, depersonalization reached such proportions that pseudo-patients had the sense that they were invisible, or at least unworthy of account. Upon being admitted, I and other pseudo-patients took the initial physical examinations in a semi-public room where staff members went about their own business as if we were not there. On the ward, attendants delivered verbal and occasionally serious physical abuse to patients in the presence of other observing patients, some of whom were writing it all down. Abusive behavior, on the other hand, terminated quite abruptly when other staff members were known to be coming. Staff are credible witnesses. Patients are not. Such an interesting point right there, right? So there were some staff members who would not beat a patient, right? But some would. And those staff members who would beat a patient, who would physically abuse a patient, did not hesitate to do that when they knew that other patients could see. But they did stop doing that when another staff member could see. Why? Well, because these other crazy patients, who cares if they see? They're not even credible witnesses. But the staff member, they are a credible witness. Okay? A nurse unbuttoned her uniform to adjust her brassiere in the presence of an entire ward of viewing men. One did not have the sense that she was being seductive. Rather, she didn't notice us. A group of staff persons might point to a patient in the day room and discuss him animatedly, as if he were not there. One illuminating instance of depersonalization and invisibility occurred with regard to medications. All told, the pseudo-patients were administered nearly 2,100 pills, including the pills of the day. Only 2 were swallowed. The rest were either pocketed or deposited in the toilet. The pseudo-patients were not alone in this. Although I have no precise record on how many patients rejected their medications, the pseudo-patients frequently found the medications of other patients in the toilets before they deposited their own. As long as they were cooperative, their behavior and the pseudo-patients' own in this matter, as in other important matters, went unnoticed throughout. Right? They're not even worth paying attention to. And by the way, the reason that these patients are not taking the drugs is because the drugs have very adverse effects. They don't want it. They don't like the way it makes them feel. Okay, reading on. Reactions to such depersonalization among pseudo-patients were intense. Although they had come to the hospital as participant observers and were fully aware that they did not belong, they nevertheless found themselves caught up in and fighting the process of depersonalization. Some examples: a graduate student in psychology asked his wife to bring his textbooks to the hospital so he could catch up on his homework. This despite the, elaborate precautions taken to conceal his professional association. The same student who had trained for quite some time to get into the hospital and who had looked forward to the experience remembered some drag races that he wanted to see on the weekend and insisted that he be discharged by that time. Another pseudo-patient attempted a romance with a nurse. Subsequently, he informed the staff that he was applying for admission to graduate school in psychology and was very likely to be admitted since a graduate professor was one of his regular hospital visitors. The same person began to engage in psychotherapy with other patients. All of this as a way of becoming a person in an impersonal environment. Next section, and we are close to the end here. So pushing through to the finish line, taking it all in, thinking deeply about all this, putting yourself in that situation. Next section, the sources of depersonalization. What are the origins of depersonalization? I have already mentioned 2. First are attitudes held by all of us toward the mentally ill, including those who treat them. Attitudes characterized by fear, distrust, and horrible expectations on one hand, and benevolent intentions on the other. Our ambivalence leads, in this instance as in others, to avoidance. Second, and not entirely separate, the hierarchical structure of the psychiatric hospital facilitates depersonalization. Those who are at the top have least to do with patients, and their behavior inspires the rest of the staff. Average daily contact with psychiatrists, psychologists, residents, and physicians combined ranged from 3.9 to 25 minutes, with an overall mean of 6 minutes per day. Okay, jumping ahead a little bit, they say, well, a lot of these hospitals are in financial straits, and so maybe that explains, that there are staff shortages, and that's why they can't pay attention to patients. Yet, the author goes on to say, while financial stresses are realities, too much can be made of them. I have the impression that the psychological forces that result in depersonalization are much stronger than the physical ones, and that the addition of more staff would not correspondingly improve patient care in this regard. The incidence of staff meetings and the enormous amount of record keeping on patients, for example, have not been as substantially reduced as has patient contact. Priorities exist, even during hard times. Patient contact is not a significant priority in the traditional psychiatric hospital, and fiscal pressures do not account for this. Avoidance and depersonalization may. Heavy reliance on psychotropic medication, aka prescription drugs, tacitly contributes to depersonalization by convincing staff that treatment is indeed being conducted and that further patient contact may not be necessary. Even here, however, caution needs to be exercised in understanding the role of psychotropic drugs. If patients were powerful rather than powerless, if they were viewed as interesting individuals rather than diagnostic entities, if they were socially significant rather than social lepers, if their anguish truly and wholly compelled our sympathies and concerns, would we not seek contact with them, despite the availability of medications? Perhaps for the pleasure of it all? The consequences of labeling and depersonalization, whenever the ratio of what is known to what needs to be known approaches zero, we tend to invent knowledge and assume that we understand more than we actually do. We seem unable to acknowledge that we simply don't know. The needs for diagnosis and remediation of behavioral and emotional problems are enormous. But rather than acknowledge that we are just embarking on understanding, we continue to label patients schizophrenic, manic, depressive, and insane, as if, in those words, we had captured the essence of understanding. I want to pause and say, this is so true. It's so important to understand somebody, especially when that person is suffering emotionally or exhibiting problematic behavior. And it takes time to understand people. And when we label them, when we diagnose them, we then operate under this sort of illusion. And the illusion is that I understand him, I understand her, I understand this person. But it's an illusion because what I understand is the construct of this condition. I understand schizophrenia, and this is a schizophrenic. Therefore, I understand this person. That's the unexamined line of thought. And it's super problematic. Okay, so the author goes on to say, the facts of the matter are that we have known for a long time that diagnoses are often not useful or reliable, but we've nevertheless continued to use them. And this was written in the 70s, and of course, that has only become way more true by now. We now know that we cannot distinguish insanity from sanity. It is depressing to consider how that information will be used. So I want to highlight again that sentence. It's one of the most important in the whole article. We now know that we cannot distinguish insanity from sanity. Now, if you're like me, you probably immediately think of people walking around on the streets, dirty, rambling to themselves some nonsense, yelling to the sky, cannot be trusted with any level of responsibility. Isn't that insane? Yeah. Honestly, yeah. I mean, when we look at the most extreme degree of insanity, it's easy to distinguish that from sanity. But the problem is there's a smooth continuum between, the most psychologically stable person to the most insane person. There's a lot of gray area. And especially for the people who are in that gray area, look at them in one setting and they look insane. Look at them in another setting and they look sane. Look at them in one outfit and they look insane. Look at them in a different outfit, like a suit or a nice dress, and they look totally sane. So I want to be realistic here. And that statement may be too bold. You know, you need to kind of qualify that statement. Again, the one that says, we now know that we cannot distinguish insanity from sanity. Again, I'm operating in good faith here. I want to be realistic. I want to acknowledge that the most extreme forms of insanity are, a child can recognize that. But still, even when it is obvious, we still don't know for sure if this person is insane by nature, or if there's some factor which, if it were removed, this person's behavior would completely normalize. In my observation, the vast majority of the people that I was just describing that are rambling dirty in the street, they're drug addicts. They are high AF. They're strung out. They're severely sleep deprived and malnourished. And if those conditions were to be removed, if they were able to sober up, if they were nourished and well rested, I guarantee their behavior would look a lot more normal, probably completely normal. With enough rehabilitation, it would look completely normal. So again, we have to be careful about what we're attributing the insane behavior to. Okay, thank you for processing all this with me, for taking in my commentary. I know I'm adding a lot of it. Moving on back into the text. So he went on to say, it's depressing to consider how that information will be used. Not merely depressing, but frightening. How many people, one wonders, are sane but not recognized as such in our psychiatric institutions? How many have been needlessly stripped of their privileges and citizenship, from the right to vote and drive to that of handling their own accounts? How many have feigned insanity in order to avoid the criminal consequences of their behavior? And conversely, how many would rather stand trial than live interminably in a psychiatric hospital, but are wrongly thought to be mentally ill? How many have been stigmatized by well-intentioned but nevertheless erroneous diagnoses? On that last point, recall again that a type 2 error in psychiatric diagnosis does not have the same consequences as it does in medical diagnosis. Again, the type 2 is the false positive, saying you're sick when you're not, saying you're mentally ill when you're not. And again, that might not have terrible consequences if you're falsely diagnosed with a physical disease, assuming you don't have to do some difficult treatment. But with a mental disorder, with that diagnosis, if that's falsely tagged onto you, well, that has profound consequences for your life. And to be clear, I just want to say too, because I'm thinking of people who have been diagnosed and now I don't want to make you feel worried that it's going to continue to have profound consequences on your life, because that is private information. You don't have to divulge that, and you don't have to think of yourself in that way, and your family and friends don't have to think of you in that way. Okay, back to the text. A diagnosis of cancer that has been found to be in error is cause for celebration, but psychiatric diagnoses are rarely found to be in error, because now our perception is primed to see that into you. The label sticks, a mark of inadequacy forever. Finally, how many patients might be sane outside the psychiatric hospital, but seem insane in it? Not because craziness resides in them, but because they are responding to a bizarre setting, one that may be unique to institutions which harbor nether people. Goffman, he says, calls the process of socializations to such institutions mortification, an apt metaphor that includes the process of depersonalization that have been described here. And while it is impossible to know whether the pseudo-patient's responses to these processes are characteristic of all inmates, it is difficult to believe that these processes of socialization to a psychiatric hospital provide useful attitudes or habits of response for living in the real world. In other words, clearly psychiatric hospitals are not rehabilitating a person and enabling them to be well adapted and adjusted to the real world. It's such a construct. The whole hospital is a constructed world that does not reflect the real world and therefore does not prepare patients to be in the real world. Okay, the summary and the conclusions. It is clear that we cannot distinguish the sane from the insane in psychiatric hospitals. The hospital itself imposes a special environment in which the meanings of behavior can easily be misunderstood. The consequences to patients hospitalized in such an environment, the powerlessness, depersonalization, segregation, mortification, and self-labeling, seem undoubtedly countertherapeutic. I do not, even now, understand this problem well enough to perceive solutions, but two matters seem to have some promise. The first concerns the proliferation of community mental health facilities, of crisis intervention centers, of the human potential movement, and of behavior therapies that, for all of their own problems, tend to avoid psychiatric labels, to focus on specific problems and behaviors, and to retain the individual in a relatively non-pejorative environment. Clearly, the extent that we refrain from sending the distressed to insane places, our impressions of them are less likely to be distorted. The risk of distorted perceptions, he adds as a note, it seems to me is always present, since we are much more sensitive to an individual's behaviors and verbalizations than we are to the subtle contextual stimuli that often promote them. At issue here is a matter of magnitude, and as I have shown, the magnitude of distortion is exceedingly high in the extreme context that is a psychiatric hospital. I just want to process that again, that parenthetical there. The risk of distorted perception of people, right, is always present. And the reason it's always present is because we are much more sensitive to an individual's behaviors and verbalizations than we are to the subtle contextual stimuli that often promote them. In other words, situational factors are typically invisible, especially if we're talking about the general circumstances of a person's life, but even when zoomed in to the present moment, the physical setting, the context that they are in, even there, the influence of those contextual factors and stimuli are very subtle, and to the untrained eye, they are invisible. The second matter that might prove promising speaks to the need to increase the sensitivity of mental health workers and researchers to the catch-22 position of psychiatric patients. Simply reading materials in this area will be of help to some such workers and researchers. For others, directly experiencing the impact of psychiatric hospitalization will be of enormous use. I feel like that's a little jab right there that he takes. Like, go ahead and try being a patient, and you'll see how demeaning it really is. I and other pseudo-patients, he goes on to say here in one of the last paragraphs, in the psychiatric setting, had distinctively negative reactions. We do not pretend to describe the subjective experiences of true patients. Theirs may be different from ours, particularly with the passage of time and the necessary process of adaptation to one's environment. But we can and do speak to the relatively more objective indices of treatment within the hospital. It could be a mistake, and a very unfortunate one, to consider that what happened to us derived from malice or stupidity on the part of the staff. Quite the contrary. Our overwhelming impression of them was of people who really cared, who were committed, and who were uncommonly intelligent. Where they failed, as they sometimes did painfully, it would be more accurate to attribute those failures to the environment in which they too found themselves than to personal callousness. This to me is a very powerful paragraph, because he's saying, I don't want to make a fundamental attribution error when trying to understand why the staff treated us like that. it's not because they are callous. It's not because they are mean. It's for them too, because of the context, because of the environment that they are in. So their perceptions and behavior were controlled by the situation rather than being motivated by a malicious disposition. In a more benign environment, one that was less attached to global diagnosis, their behaviors and judgments might have been more benign and effective. Ooh-wee. We just ran a marathon intellectually, and I thank you for doing it. You just crossed the finish line. Not much more I need to say. That is evidence of the power of the situation to shape human perception, cognition, emotion, and behavior. And there was much more in the way of commentary on broader things like the mental health system. But the final point that I want you to take away is that this is an example of the power of the situation. And so much of human behavior can be explained by the power of the situation. And that does not mean to say that you are completely determined to be the way you are because of the environment that you're in. It's people have a phenomenal ability to transcend circumstances, for their traits to shine through even in situations that would squash those tendencies in other people. So we're not saying that you are completely determined to act the way you act by situations. It is possible to transcend them. So in other words, we don't want to overestimate the power of the situation, but we also definitely don't want to underestimate the power of the situation. And that's what most people do. They underestimate the power of the situation. So this study that we just read together, again called On Being Sane in Insane Places, is a particularly powerful example of the power of the situation.